Hello and welcome to the Processes and Documentation in the Emergency Department module. Let's first take a look at triaging. The word triage comes from the French word trier, which means to sort or select. Its historic roots for medical purposes go back to the days of Napoleon when triaging large groups of wounded soldiers was necessary. Over the centuries, triage systems have evolved into a well-defined priority process, sometimes requiring specific training depending on the setting or organization that uses them. Let's take a look at an example of a triaging system. Here we can see the RESAs or the red zone are cases which require immediate attention for critical life-threatening injury or illnesses. Then we have patients who are triaged to the yellow zone, who are patients with serious injuries needing immediate attention. And finally to the green zone, who are patients with less serious or minor injuries, non-life-threatening, delayed transport, which eventually will need help but can wait for others. Now let's take a look at a case presentation. So a case presentation is a formal communication between your healthcare professionals regarding a patient's clinical information. So here it's important for you to be delivering many case presentations as your communication with your superiors actually begin here. So there is a specific process of presenting a case and we will go through it shortly. Just like any other departments, the emergency clocking starts with general clocking as well. Here we will be showing you how you'll be presenting cases to your superiors for referrals or even for end of posting exams. So always begin your presentation with an opener. Your case presentation would need the patient's details such as name, age, gender, and chief complaint. The chief complaint is the reason that the patient sought medical care in his or her own words, or if brought in by an ambulance call or a passerby. Subsequently, it will be presented as how you received the patient. Do mention the comorbidities when you're able to gather those information. Next would be history of presenting illness, of course. Elaborate on why the patient sought medical care. Describe the events that preceded the patient's presentation in chronological order. And next, moving on to past medical or surgical history. Here, we would want to know the patient's previous medical conditions, any past surgeries, timing and reasons for past hospitalization, their current medications, and not to forget allergies to medications as well. As we move on, we will have to cover the family history as well, finding out any relevant conditions that run in the patient's family with an emphasis on first-degree relatives. Social history after the family history. This section should include information about the patient's living situation, occupation, alcohol and tobacco use, and any other substance use. Sometimes the financial status is important because in emergency conditions that might require urgent intervention at a private center or any centers that are semi-private, they might require some financial backup. Next, we move on to physical exams, a quick review on your physical exams. So here you should report by first beginning with the patient's vital signs. Your general impression of the patient should include whether or not he or she appears sick. The results of your systemic review, including your respiratory, your cardiac, abdomen, as well as your neurological findings, can be stated here. And finally, you should conclude your presentation with an assessment and plan. This is the most important part of your presentation. So let's go through the components that you have to look out for in a trauma case for case presentation, as trauma cases have their own specific case presentation style, which begins with A, B, C, D, E. A for airway. Here you want to look at the patency of the airway. You can suction the airway first or do a chin lift or jaw thrust. Provide a nasal or oropharyngeal airway if you suspect airway compromise. Orotracheal intubation or cricothyroidotomy in emergency situations where there is obstruction above the laryngeal level. Recognize the potential for cervical spine injury and maintain the spine in a safe neutral position with a cervical collar until clinical examination and radiological findings exclude injury. Next, we have B for breathing. Administer high flow oxygen. Assess the chest by inspection, palpation, and feeling for the trachea. You may then move on to recognize and treat the common causes of arrest here. That would be ATOM FC, your airway compromise, tension pneumothorax, open pneumothorax, massive pneumothorax, flail chest, and cardiac tamponade. And lastly, for C, we have circulation. So here you'd want to assess for looking at any presence of external hemorrhage, looking at the skin color, pulse check, BP measurement, and neck veins. Moving on, we have disability, and this is where you assess the GCS, looking at if the patient has eyes spontaneously open, able to communicate verbally, and also respond to verbal commands. You may also want to take a look at the 5 N's, which is N for nogging, raccoon eyes or battle sign, N for neck, looking at presence of knuckle rigidity or neurogenic shock, ENT, looking at otorrhea, rhinorrhea, hemotympanum, needles, the next N for IV drug abuse, and another N for neurology. Last but not least, let's complete it with the E, which is exposure or environmental control. So ensure the patient is exposed well so that adequate complete examination can be performed. Prevent the patient becoming hypothermic and measure their temperature while you're exposing them. Now let's take a look at the case example. We have a 35-year-old male who was brought in by the ambulance call from a passerby. He was brought in after an alleged motor vehicle accident. Patient was brought into the ED by the ambulance after an alleged motor vehicle accident this morning. He was a pillion rider. The motorcycle was hit by a car which was coming on a high speed from the opposite direction when the rider was making a turn to the right junction. Passerby claims the motorcycle was hit and the patient and the rider skidded on the ground and hit the edge. Patient was using his helmet and was buckled. He currently sustained pain on the neck region and vomited once post-injury. He denies any loss of consciousness, retrograde amnesia, or ENT bleeding. Now, moving on with examination, you want to mention regarding patient's airway, which is patent, speaking in full sentences, with no compromise of the oral cavity, no facial injuries, no noted cervical tenderness on the collar. The breathing part, you want to document the respiratory rate. If there's any tracheal deviation, chest rise, which is equal, chest palpation, that's negative, to any abnormal thrills, percussion resonant, and entry of the air equally bilaterally when you auscultate. Circulation would encompass the hemodynamic status as well as looking for any possible occult bleeding while examining the abdomen. D for disability, that is to look at the GCS, the pupils, as well as the DXT or the capillary blood glucose. Finally, E, which is looking at the temperature and exposing the patient well enough for examination. The adjuncts that can be carried out would be your log roll, which is negative, no step deformity or tenderness, no bruises, and also a parectal examination while you're at it. A fast scan to look at presence of any free fluid or pericardial effusion, which we will be covering in this topic under the procedures, as well as radiological investigations, where we want to look at cervical x-ray and the chest x-ray as well as pelvic x-ray if indicated. Now let's move on to progress reviews. So how does a progress review work in the ED? This department may not need you to follow up with your patients on a daily review like in the wards. However, some of your patients who come in would need an admission to a referral or respective department. Therefore, until the patient is still in ED, they're still in your responsibility, within your responsibility or care, and they are placed at the observation ward. All plans, including medications, blood tests, imaging that has been ordered, needs to be carried out accordingly in all zones. So you will need to write or type in your review of each patient when they have not been reviewed yet, as long as they're still in the emergency department. Document promptly so that the nurses will be able to carry out their part on the plan as well. This is the observation ward, and here you'll be in charge of managing the patients that are transferred from the other zones while awaiting for disposition or discharge. Cases will be handed over to you upon transfer to the observation ward. Rounds will be done daily per shift, usually 3 to 4 times a day. Cases will be presented to the emergency physician and medical officers who will be doing the rounds here. Importantly, the impending results and plans to be carried out upon reviewing results need to be updated. Emergencies occurring in the observation ward should be immediately informed to the medical officers or EP immediately. Let's move on to handovers. A handover occurs when a house officer hands over the responsibility of care to a patient to another house officer, for example, at the end of his or her shift. So as a house officer, you will need to follow a well-devised format to ensure pertinent information regarding the patient is not missed and to avoid wrong information being passed over. So there should be information regarding the past events, which means details of what has been done for the patient as well, the patient's progress for the day or before, the present plans and events, which include details of plans that have not been carried out, blood investigations or formal reporting from radiographic imaging if there's any, and future events that would be details of upcoming plans given by the specialist or MO, as well as important or urgent events to look out for on a patient's condition. So when service from another department is required, a request is made. Here, house officers are assigned to make requests following the plans in the daily reviews. When you have received the patient you saw and discussed with your medical officer or EP, many requests are made. This is not only made from the ED, but the patient is referred to another team, hence they would have their own special orders or requests too. So first of all, you may want to identify what is the test to be requested, identify the departments involved, then moving on to identifying the officer in charge of the request, outlining the purpose of the request, urgency of the test, and how the test will be able to aid the diagnosis and management of the patient, identifying the criteria needed for the requested test, and finally, identifying the documents that are required to be filled. So here, first of all, you'll need to complete the request form for the test, call or meet the medical officer in charge of receiving the test, and once granted, informing the nurse on the plan to transport the patient over to the location of the test or collect specimens for the test requested. Don't forget to document the trail as to who granted the test, when the test is planned for, and preparation steps for the patient. This is an example of tests which require verbal requests and do not need verbal request. Next, let's move on to referrals. So referrals are made to other departments for management input, suggestions, or if their skill sets are required in the management of a patient. And here, majority of your time will be making referrals. So be familiar with the process of making a referral, where you first have to identify the purpose of the referral, identify the departments involved, the officer in charge, calling the medical officer or the specialist in charge of the referral, and finally documenting the trail. So an example of a referral from the emergency department to the surgical department would be, for an example, you may start off by communicating clearly and confidently your speech, beginning with introducing yourself. So good morning, Dr. Alex. I'm Dr. Betty, a house officer from the emergency department calling from the green zone. You can then move on and provide a brief patient's details as well as the reason for referral in the opener itself. Don't forget to thank your team's input on the patient's matter at the end of the referral. Now, moving on to the final part, which is discharges. A discharge summary plays a crucial role in keeping patients safe after leaving a hospital. So, hospital discharge summaries serve as the primary documents communicating a patient's care plan to the post-hospital care team. House officers here are responsible for formulating a complete discharge summary and carrying out discharge work as stipulated in the summary. So there are 6 main components in the discharge summary, which include the reason for presentation, significant findings, procedures and treatment provided, patient's discharge condition, patient and family instructions, as well as the attending physician's signature. And now, what do you need to do prior to allowing patients back home? You'll need to ensure that their general condition is well and all plans are carried out. Remember to order discharge medications early so patients will receive them on time. And should there be a need for medical certificate to be issued, inform your medical officer or specialist in charge to fill the certificate before the patient leaves, as it will be included in their discharge docket. So we have come to the end of this topic. We hope it was insightful and thank you for your time.